Good afternoon. This is Erin with the Department of Medicaid. It's not quite 2 o'clock, so we'll give it just a few moments before we get started. Good afternoon. It's officially 2 o'clock and the waiting room is clear. Keith, I currently show yourself, Linda, and Troy logged in. We need one more for a quorum. Would you like to give it just a moment longer?
Yes, please, if you don't mind. Linda or Troy, if you all have contact numbers for any of the other members, if you wouldn't mind maybe texting them. I don't have everybody's information, or we can ask them to jump on.
I'll text Dana.
Okay, thank you.
Keith, I did want to also mention we will only have the commissioner with us till about 2:30. She has another meeting.
Okay, very good. Aaron, do we know if Steve Bechtel is going to be able to be on this call or not?
I believe the commissioner is here on behalf of Steve today.
Okay, very good.
We got the big dog with us today.
That's all good. I think right now with everything happening the way it is, everybody is kind of starving for some information. So
We'll give
if
it
you
just
could
a
have
longer. As soon as I clear the waiting room, it fills right back up. So
okay, very good.
it looks like Steve is joining us. So once he gets logged in, that'll give us a quorum.
Okay, Steve Eubank.
Yes. Oh, sorry.
Okay.
I probably should have clarified.
That's okay. It's all good.
And you have a quorum. I will turn it over to you, Keith.
Okay, thank you very much. Good afternoon, everybody. Thank you for joining us today for our EMS Medicaid TAC meeting. We do have quorum now. Let me ask to have the members that are on the call, if everybody's had an opportunity to review the minutes, if we could get a motion to approve.
Motion to approve.
Got a motion from Troy. Do we have a second?
Second.
All right, we got a second from Steve. Steve, is there a way you can come on camera for the vote?
I can see him.
Okay, very good.
I
Outstanding.
can't
Thank
see
you.
Linda, but I can see Steve.
Okay, so we got a motion and a second. Is there any discussion about the minutes? All right, with no discussion, call for the vote. All those in favor, please signify by saying aye.
Aye.
Opposed?
Aye.
Any abstentions? Very good, motion passes. We really had nothing under old business that we needed to discuss after we had the last discussion about the PCS forms. We were able to get word out to the EMS providers to let them know what the delineation was between needing the PCS form or needing the actual pre-certification. So that one we've been able to put to bed. Under new business on the agenda, essentially the number one question that I'm hearing and in speaking with a few others, the biggest question is with the big beautiful bill that passed, everybody's heard that this is affecting Medicaid in various ways. We've got our GEMT program and the newly passed program that just went through with this last legislative session. And right now, there's a lot of questions swirling about regarding how will the changes that the bill, how is that going to affect EMS reimbursement for Medicaid? That's why I was hoping that Steve would be on, to where maybe he would be able to give some kind of indication, or the commissioner, if she could opine on what type of changes we may be looking at. Granted, this just recently passed. We know you all are probably looking at it from so many different angles, but I'd like for us to be able to give the folks within EMS a bit of a heads up as soon as we know how this is going to affect us and when it's going to affect us, so that perhaps we know what actions we need to begin taking. So with that, I'd like to ask either the commissioner or Steve to jump in and brief us on what you can about this.
I think Steve is traveling today. He is gone to a conference, Steve Bechtel is. So I will try to fill in as best I can for him. You know that Steve is very versed in all things Medicaid budget and reimbursement and the directed payments and taxes. But I can tell you what I know, and that is the bill did pass. Some people are calling it House Resolution 1. Some are calling it, the Big Beautiful Bill Act, or OBBA, they're calling it, but it has passed. It does have some significant implications for Medicaid funding, particularly as it relates to provider taxes and state directed payments, of which I know that we have, both of those would impact the ambulance providers. So for example, the reduction of provider taxes begins in federal fiscal year 28, which means the providers would start seeing an impact in October of 2027, because it's the federal fiscal year. So that would start in September 2027. And right now, most of these taxes are collected by revenue, but DMS does collect a few of them. But basically, the budget reconciliation requires all provider taxes to be frozen at current levels, and the current level is a 6% maximum. And we have to lower those taxes that we collect by 5% each year, starting in federal fiscal year 28 until we reach 3.5%. So what that means for ambulances is that the current ambulance tax is used to fund the state share of the ambulance directed payment program, or we call that the APAP. And it's going to be subject to the decrease in tax levels. And the tax level is going to need to decrease every year under the state directed payments. So basically what that means is we're going to start seeing a decrease in 2028. We have been looking at some estimates to see how that may play out, but we do see what I think is a pretty significant decrease from now through calendar year 2031 and 2037. So it spans a period of time. So it's going to be reduced each year, but we know that each reduction is detrimental to our ambulance providers. So what we're seeing in the form of the tax, what we've estimated, for example, in the ACR moving from what we're currently paying to 100% of Medicare payments, is about $53 million a year right now. So ambulances, based on what we're seeing, ambulances are getting around 62.4 million per year in calendar year 26. So when we start reducing that by 10% each year in 2028 is when the calendar year 2028, which is when we think we'll see the first reduction from the 62.4 million down to 56.1 million. And then in 29, we would see another reduction down to 53.3 million, almost 54 million. is what it would be, because it's down to about 53,963. But that 53 million would stay from 29 all the way down to 2037. That would get to 100% of the Medicare costs. So again, we see a significant impact on our ambulance providers. Not as significant, for example, as our hospital reimbursement program that we see, but still, any decrease is going to have a major impact on ambulance providers, and need to start planning now as to what you can do, what we need to do as we go forward. Again, it starts in 2027. You have a little bit of time, and I'm not sure what may happen between now and then, but reducing those costs down to get into the average to the Medicare limit is what we've been looking at. And again, that's an estimate on what we see right now, and we're going to continue to look to see how this may be impactful as we go forward. And I hate to deliver bad news, but the bill is the bill, and that's what we have, again, estimated going forward. It starts in 2027, and it appears that in 29, you'll be at we do the reductions. It would be, you would be at that, or it was 2029, ambulance providers would be at the 100% of Medicare that the bill caps. So the bill caps, if it's for Medicaid expansion states, so Kentucky is a Medicaid expansion state, it caps our state directed payments. They can be no more than 100% of the Medicare fee schedule. And for non-expansion states, they allow them to go up to 110% of Medicare. So that's where we're at. Not good news by any means. I think that, we've been monitoring, we've been watching, we've been very concerned about the impact that this was going to have. But basically what the federal government is doing is reducing the amount that they will pay, and states would have to increase the amounts that they pay if we wanted to keep providers whole. So this next budget cycle is going to be very critical. It's going to be very difficult. Everybody's going to have to make some difficult choices, because again, this tax, it not only impacts the ambulance and the directed payment, it also impacts our hospitals, our home health care, one of our supports for community living waiver. So it's those four provider types are the ones that are going to be the ones most dramatically impacted by the language and the requirements.
Do you want me to send it to you, or do you have it?
What?
Lord, hold on.
Okay. Just off the top of my head,
I have it.
one of the things we had heard before.
Does that make sense?
I'm sorry, I can't find who's talking to mute them. If you're not presenting, can you please mute yourself? Sorry, Keith. Sorry,
No,
Commissioner.
you're fine. Thank you, Aaron. No, I appreciate you doing that. So, Commissioner, based off of what we know and what it looks like, I'm really torn here, because we've already got EMS services that are choosing not to pick up patients in hospitals that have Medicaid, because they won't accept the low reimbursement, which then puts the onus back on the hospital then to find transportation. And in my particular case, I have to provide it, which means I'm going to have to be the one to take the loss. At the end of the day, we've got to get the patients moved. I mean, that's just bottom line. But do you foresee the state, or is there any appetite that you know of from the legislators so far to draw into the rainy day fund in order to try to lessen the impact of these financial hits? Because I mean, we're already getting a low reimbursement as it is. To take this on top of it, when our costs are going up, not down. And I know I'm preaching to the choir, but we're going to have some type of solution. And my guess is there's going to be a lot of door knocking going on at the legislature during this next session. I guess more than anything, I'm curious as to what actions that you can talk about from a Medicaid perspective are you all looking at potentially doing to try to offset the sting of these cuts?
Yeah, I think, the legislators, they determine the budget. I think that what we definitely have to do is provide the impact that we see on every provider, but with specific to the directed payments. Those providers, the ambulance, the hospital, and the home health agencies look like they're the ones that are going to be impacted. We need to provide them with the information that we have at hand. And as you know, the budget is conducted, is developed, and it is put in place for 2 years. So our current budget is 26. The next budget is going to be 27 and 28. And so that's the period that we have to really be looking at what is going to really impact, how much money do we anticipate our providers are going to lose, and how can we make that up? Is it going to be, is there room for increased payments? If so, what would that be? And again, this is a situation nobody wants to be in. We need to definitely figure out, how we move forward. Some other provisions that are in the bill that are going to impact providers, they directly relate to members, but it's also going to impact the providers. For example, we are going to have to have work requirements for our Medicaid expansion members, and they're going to have to demonstrate on a routine basis that they're doing that. If they don't, eligibility will be terminated for those individuals. If we, as the state agency, cannot verify that they meet the requirements, or either the individuals themselves can't meet the requirement, that would be one, be less provider, or lower eligibility levels in the state. So which would mean there would be a little bit more individuals without health insurance. We also are going to have to implement some cost sharing. Now, it's very vague in the bill. We have to implement cost sharing for Medicaid expansion members. And we up to $35 per service, but there are many services that are exempt from that. However, I did not see transportation as an exemption, but again, that would be a decision that would have to be made as to what level, what services. We also will need to conduct more eligibility determination services for our members. For example, currently, if an individual is enrolled in Medicaid, we redetermine their eligibility on an annual basis. Now we're going to have to start doing that on every 6 months. Also, the retroactive coverage. Currently, if somebody applies for Medicaid, we ask them if they have medical bills. And if they have medical bills in the past 3 months, we will backdate their eligibility for 3 months. For Medicaid expansion members, we can no longer do that. It has to be the month that they apply. Everyone else is going to be 2 months. So that basically means if they have bills, any transportation that they may have had, then that will not be covered by Medicaid going forward. So there's several things in this bill that appear to be member related. However, we know that anything that impacts that member is also going to have an impact on our providers. So I think going forward, I know the next discussion is Medicaid changes for upcoming legislative session. I don't know even how we think about that right now, but we definitely have to include everything that's in this bill and the impact that it's going to have on the Medicaid program going forward. Because even if we're not going to see it for 2020 until 2028, we have to start planning for all of that right now. And so we have to get good information, good estimates in the hands of our legislators so they know exactly how this is going to be impacted. Now, there is a provision in the bill that provides every state, there's $100 million for a rural health transformation fund, but that $100 million is spread out across every single state for 5 years. So it's, millions each year. What is it? It's 100 million for 5 years. So it's 50 million a year or how my math isn't good right now. I'm thinking, but if 100 million spread out over 5 years, then that's 20 million per year. And that's for all states. And that is, states must apply for that through an application or a grant application, and that grant application has to be in by December of this year. So that's going to be a pretty aggressive timeline for us to try to get that in, but it's supposed to be help with, again, rural transformation, and it's hospitals and providers. So we have to get that in again by the end of this year, and we don't have a lot of information to go on, but that's one thing that may be able to help. But again, it's just a 5-year grant. So once we get that, what do we do?
Sure. And if there's anything that we can help provide from the ambulance side, I think all of us will do whatever is needed to assist in collecting the data, whatever it takes to help. With what you just said and what we're seeing, before all of this started up with this particular bill, there was scuttlebutt that basically Moab was going to be looking at Medicaid for the upcoming session. Is this going to be on top of what the legislators are going to be dealing with Moab, or what's your opinion on that?
I'm not sure. I want to correct myself. I have the bill in front of me. I've been reading it today. So there's a lot of nuances and a lot of references in the bill. So the Rural Health Transformation Program is $10 million a year for 5 years. So it is $50 million for 5 years for every state, but it's 10 million per year from 26, 27, 28, 29, and 2030. So each year, all states will be able to divide up $10 million or 10 billion. I'm sorry, $10 billion each year. But that's all states. So again, all 50 states will be able to divide $10 billion up if they get in an application by December 31st of 2026. But now, to give you an idea of what that may do and help, in Kentucky, our hospital reimbursement improvement program, our HRIP, between our hospitals and our universities, bring in about $5 billion a year. So if there's 10 billion being divided up between 50 states, it's not going to be a lot of money to help offset the loss that we're going to experience.
Wow.
So yeah, so during the legislative session, again, I think it's really important for us to get a really good read of the bill and the true fiscal impact it's going to have on the Medicaid program and our providers, and get as much information as we can to the legislators, to the governor, to everyone who's going to be involved in charting a course forward as for the Medicaid program, because this is significant. These cuts are definitely significant. I think that we've been saying that we've been really concerned. The original bill that the House created had a grandfathering in for the state directed payments, and this one does not. It has us phasing out. The resolution has us phasing them out over a period of years, beginning in 2028. So, and we don't have a lot of time. We have this year to set our budget for the next 2 years. We have until June. Well, this legislative session starts in January. So it's going to be really important to set that course and get information on how detrimental this bill is to our providers.
Sure. And real quick, ma'am, I know you got to bolt here in just a moment. Is there any of the members of the committee that have a question for the commissioner you'd like to ask real quick?
And probably people are in shock again. Steve is out. Steve Bechtel is out. I don't know if he could have delivered this news any better, but he's probably out because he knew it was going to be bad. bad news, sad news. But we will work with you in any way we can to make sure we continue to meet the needs of our members and our providers, such as you, who work so hard on a daily basis to deliver them. I do see Linda has her
Yeah.
hand up.
Go ahead, Linda.
Okay, can you hear me?
I
Yes,
can.
ma'am.
Okay, so is this going to affect both the APAP money, the GMT money, and the ASPP money that we were anticipating?
Yes, I believe it impacts both the taxes and the directed payments. So it will, and I don't know when the next meeting is, but I know that Steve Bechtel will be back in town if you all want to, reach out to him and get some more information, some more figures. Again, these are estimates that we've looked at based on the information at hand today, always subject to change. But it will impact both the APAP and the directed payments.
We hadn't started even receiving the directed payments yet. I didn't know for sure the way the bill was reading, if we were going to be allowed to still benefit from it in any way.
Yeah, you will up until this starts taking effect. I think that one, the directed payment, you won't start seeing an impact on that until calendar year, it looks to me, until calendar year 29 on the directed payment. So you should have a little bit of time there to where you're going to be receiving those directed payments.
And one other thing, as this revenue goes down or the limits come into play, the assessment or taxation to the providers will go down as well as the reimbursement, correct?
Yeah, it goes, yes, I say yes, but I don't know that that's the appropriate answer right now, because it all depends on what happens in the next legislative session and what the budget looks like, and if there's any way to make up for those lost funds, because the tax will be lowered by 0.5% each year until we get down to 3.5%. So those taxes are going to be reduced, which that's what's used to make the state share payment of those services. So again, if there's no money in the budget and the taxes are reduced year over year and there's no money for increased payments, then the payments would be reduced. Now, however, legislative session coming up, budget, you all will need to advocate for your provider group. We will continue to give you the information that we have at hand so that you all can make the best have the best conversations you can and have the best information that we have available to us and as updated as we have it.
Okay, thank you. Oh, I do know there was one other question. I'm sorry.
That's okay.
As the cost data reports that we've done for Medicare, if they show that Medicare needs to increase their rates, will this also affect the change in rate for
Yeah,
us?
we will be paying 100% of the Medicare fee schedule, Medicare rates. So if Medicare increases, then these would increase if Medicare increased their rates.
Okay, thank you.
I wish I had better news for you all. And again, thank you for everything you do, but we do have a lot of hard work ahead of us, particularly in this upcoming session and as it relates to the budget and how those new funding will be allocated as we go forward.
Okay.
Thank you all so much. Another question?
Yeah. Are there any more questions from the group? All right.
Thank you all so much. Please reach out with any questions.
Okay. Thank you, Commissioner. Real quick, Troy, is from your perspective with CAPA, clearly this is going to be something I think we're all going to have to probably be as in lockstep as we can possibly be between all of the different groups in Kentucky, whether it be CAPA, the air providers, basically all of the groups, educators, you name it. Do you think that from the CAPA side, there would be an opportunity that we could schedule some type of a meeting with providers to talk about a united message that we give out to legislators across the board about what we need to have happen, or what's your take as far as from the Kappa side of things?
We got to meet with Kappa. You're right. I mean, it's going to be on all of us. We're all going to have to kind of unite on this. But I've got to get with the Kappa board. We have not formally met on this yet. So, but that will be the strategic plan, I do believe.
We have a meeting next Thursday,
Yeah.
so we can definitely address it there.
Yep.
But besides Kappa and our air providers and the education group, are there any other groups that you all are aware of that commonly, well, firefighters group, is there any other groups that we need to call into this discussion? So again, we can hopefully all provide the same message to our legislators.
Maybe KLC and KCO.
Yeah, that's actually a very good point.
Yeah, I'm sure KHA is going to be doing a lot. I say KHA, but Keith, we're both hospital based, and
Yeah,
this is going to affect them greatly too.
Yeah.
So,
Yeah.
it, movement comes with power of, as many people as you can get behind you, but we have to
Mhm.
meet all of them. So
Sure.
It's gonna
I'll
be
get
close.
with Donna Little to see if I can get some time, Troy, to where those of us that are hospital based, we can share with her what our concerns are, and hopefully get them as an organization to back us as much as they're going to back the hospitals on this. And I feel they will. I think this is going to be a hit that all of us are going to take, some more than others, clearly. But at this point, I think we got to throw the hat in the ring to get as many groups as we can involved to try to get the message. So that's probably be the next thing is what is the message we're going to need to come with, so that all of our EMS providers are being represented with a plan to go to the legislators or anybody else that is willing to listen to us.
Yeah, I agree.
All right. So we got the firefighters, fire chiefs, air medical, KLC, KCO, KHA, Kappa, Instructors Association. Linda, can you or Dana think of anybody else that you all work with on a routine basis that we should include from a lobbying perspective?
Well, I think we really need to, it's already been mentioned, the Firefighters Association, but they're very strong across the country. And we know this is going to be hurting not just Kentucky, it's going to be hurting everybody. So we really need to push and lean on and encourage, keep up to date on what they're doing with it as well.
Mm-hmm. Agreed.
Hey, Keith, I was kind of interested. She was talking, the hardest impact was, of course, hospitals, EMS, and home health. And I mean, do you think they're going to look at that, when they present this to the governor's office or legislation, who it's going to affect the most, and where EMS actually shows up in that, how it's affected? I don't know. The hospitals, they've got a lot more money. They're a lot bigger, but operations, the to stay afloat, the ambulance service industry's so low to start with.
Right. No, you hit the nail on the head, Troy.
Yeah, I wonder, if we need to really look at that and the effect. Yeah, they might it might affect some services, and I'm not blaming, I'm not trying to throw stones here, but okay, well, they might not be able to do some of the services that they normally do as a hospital, but for
Mhm.
EMS is we won't have an ambulance service.
Right.
I think there's a big difference on how it's affecting us versus other healthcare services. So,
Yeah, no, I think you're spot on, and it's already with the non-emergency rate being as low as it is. taking a cut from a little basically leaves nothing. And when I mentioned a moment ago that there are ambulance services now that are outright refusing to do non-emergency Medicaid transports, um, I wasn't exaggerating. I mean, I've had two in the last few weeks that I've had to deal with from my private or from my employer perspective, that we've had to rearrange schedules to get taken out because the people that have been taking care of their community residents have chosen that they're not going to do it anymore because they simply can't afford to get a very small reimbursement for the amount of time and mileage it takes for them to go to the hospital to get the patient to take them home. It's not about making any kind of profit. It's the point that they're not even getting close to what their actual costs are. That's one thing that I was really hoping that the Medicare report that we all had to put into, that Linda just mentioned, was going to open some eyes as far as what our unit of service cost is for every single transport we do. This was our big opportunity to actually potentially get our rates to raise to where we could at least break even. And now it appears that we're back to square one again on how are we going to try to get this fixed. So it's
Definitely not going to be able to get anyone to come in and help you anymore. If you're a small rural hospital and you're needing help getting transfers out,
Yep.
to get those other services to come in and help at a loss, you're just not going to be
Mhm.
able to get it. So,
Right. I hate to make an analogy, but we no longer have to worry about mother jugs and speed with people racing to get a run to be able to get the reimbursement. If anything, now it's going to be the complete opposite of that. All right. That, as far as from a new business perspective, we just had these two items on the discussion. And this meeting was probably a lot of information for the EMS folks, maybe not so much for the MCOs that are online. And for that, I apologize. But when we say that we're going to have to all work together to get this taken care of, I really do mean that, including even MCOs helping us if at all possible, because we really are going to get to a point that EMS services across the state are going to stop moving Medicaid patients if we're not able to do something about this reimbursement rate. And I think it's going to take all of us to get some change made in order to where at least we can cover more of our costs than what we're able to do now in an environment where the financial resources are shrinking even more. So, all right. With that, is there any general discussion that the group, MCOs, or anyone else would like to bring up? Okay, hearing none, we have, as I'm assuming, no recommendations to take before the MAC. Does anybody have anything that you would like for us to bring up to take to the MAC, or stay status quo at this time for that?
Keith, can I give you a quick update on the MAC?
Yes, ma'am, absolutely.
Um, as I'm sure you've heard in some of the MAC meetings, I know you're the MAC representative for this TAC. Due to final rule that went live July 9th, we have created a new beneficiary advisory council, which we'll be calling the BAC, and incorporating and trying to come into compliance with that federal rule. 25% of the BAC will be rolled into the MAC. With that being said, the BAC also has to meet prior to the MAC, so the current MAC schedule has been canceled. We're hoping that the first BAC meeting will kick off sometime mid-September, which would have the first, what I'm calling the new Big Mac, meet sometime towards the end of September. So there's a little bit of changes on that.
Okay.
As far as the representatives, providers, and then just rolling the BAC members in, the commissioner now appoints those versus the governor's office. So just a few slight changes. As we have the new BAC dates set out, all of that information will be sent. The BAC has the right to meet privately. So that information may or may not be shared for public meetings, but as all of that unfolds, I will keep you guys up to date and sending that information out moving forward.
Okay, so to clarify, does anything the BAC do affect the TAC to go to the MAC?
No, sir. It's
Okay.
basically it's the beneficiaries committee and it's
Okay.
their opportunity to bring their voice to the table. We do have a few tags such as the IDD tag, persons returning, consumer rights that do have advocates, lived experience caregivers, but this is just a committee that CMS is requiring all states to do to give the beneficiaries and the members that you serve the opportunity to bring barriers and issues that they see from their perspective to the MAC and to Medicaid.
Okay. I used to think the Air Force was bad about acronyms, but my goodness, the state government's giving it a run for its money, and federal government. All right, thank you, Aaron. I appreciate the information. All right, our next meeting is October 27th from 2 to 4. Hopefully, we will be able to meet before then, not as an official TAC meeting, but with the as participants with either Kappa, KLC, KHA, whatever the group is that we're also members of, pooling together in order to come up with some type of a agenda and a unified message to be able to start pressing our elected leaders with. So I'm sure there'll be more to come out on that, and I will, as soon as I hear of any of the dates or meeting topics, I will certainly send it out to the TAC so our members are aware of that as well. And if you all don't mind, if you all hear of meeting dates from these different organizations, if you wouldn't mind passing it along as well, so that we know that we've got everybody pooled in and communicating with one another, that would be fantastic. All right. With nothing else on here, we're up for adjournment. Do we have a motion to adjourn?
So moved.
We got a motion from Mr. Walker. Do we have a second?
Second.
All right, we got a second from Mr. Eubanks. Any discussion? All right. All those in favor of adjourning, please signify by saying aye.
Aye.
Aye. All right, very good. Thank you all very much. Until our next meeting, I hope everybody stays safe and healthy, and we'll talk soon. Thank you all.
Thanks, everybody. Have a great day.
You too.